who will be speaking on imaging in acute chest pain.
Good morning. We're going to different area. So the technology of cardiac CT is actually very, very young. It was born in the beginning of this millennium, and it has made such a tremendous progress that this year, 2012, the New England Journal of Medicine published an article stating that CT angiography is safe for discharging patients with possible acute coronary syndrome. So this morning I'm going to briefly review the technique, the advantages of this technology, application for investigation of acute chest pain, and I'll touch shortly on advanced applications. So what is cardiac CT angiography? Briefly, it's a CT angiography, however, we have the constant cardiac motion which we should overcome. And this was overcome by using cardiac gating, which is registration of the ECG during the acquisition, and we need for that to give the patient beta blockers and to lower the heart rate and get a stable heart rate. We inject contrast in large volumes and fast, and we aim at acquisition while the contrast is in the left heart system. This doesn't work, let's see, okay. So when the aorta is full of contrast, we ask the patient to hold his breath, and acquisition starts, and it's mainly on 64 slices of quite a few seconds, like 5 to 10 seconds. We take only those pictures that were acquired during mid-diastole, because this is the time where there is less motion artifacts, and this will be the reconstruction we will analyze first. This is how the actual acquisition look like in the axial view. You can see how tiny are the coronary arteries, and this data, and this is also the time it takes for this acquisition actually. And then we transfer the data for post-processing for three-dimensional reformations and carried multiplanar reformations of each coronary artery itself, looking for eccentric plaques. In the beginning, retrospective cardiac gating was used, meaning that radiation was continuous throughout the cardiac cycle. However, we are looking only for those motionless images which are at 75% between the R and the R, but we could have other phases in order to have more data. But if we need only the mid-diastole, we could give the radiation only at that time, and later the axial prospective gating technology came, which reduces the radiation very significantly, and if the patient has stable, slow heart rate, we can get wonderful images with significant radiation savings, and this is how it goes on a 64-slice scanner. It's one step of radiation, and then one step the table movement, and again 8 cardiac cycles, 4 are taken into account, and this is very low dose. Before performing the CT angiography, we'll do a calcium score, as it was shown that there is a strong correlation between the coronary artery calcium score and future cardiac events. This is also allowing us to have a large field of view and see the lungs. As you can see here, this suspicious pulmonary nodule which was investigated for lung cancer. Quantification of diameter stenosis is done, is done by measuring the diameter with a reference next to it, while only stenosis above 50% is considered significant stenosis. Now, if we compete other cardiac imaging tests, we need to show the advantage of cardiac CT, and all those points I'm going to review shortly in order to prove that it is really and advantageous technology. So first, do not harm your patient. Contrast, what about the contrast? We need more contrast doing cardiac CTA when compared to other anatomical options, invasive coronary angiography. However, these two publications, one of them is from the ESUR Contrast Media Safety Committee Guideline, state that intravenous injection, like we do in cardiac CT, is significantly less harmful than intra-arterial injection, which is done during invasive coronary angiography. This might be due to the fact that the catheter itself may dislodge some cholesterol emboli, which will go and infiltrate in the kidneys and cause kidney damage. So there's actually almost no report on contrast-induced nephropathy due to coronary CT angiography. And what about radiation? The vendors really work hardly in order to reduce the radiation dose, and we do that by multiple technologies. First, we use the prospective gating, as I told you before, and then we can use now low kV imaging, which is significant reduction in the dose. However, the noise is much increased. And in order to overcome this noise, we have now the iterative reconstruction algorithm, which is a way of reconstructing the imaging using statistical models which throw out those pixels that represent artifacts and only enhance those that represent really the anatomical image. And this is, by the way, used for every chest imaging protocol, including pulmonary CT angiography, if the scanner has this technology. So if we compare the cardiac CT to other imaging studies of the heart, you can see that thallium myocardial perfusion imaging is associated with radiation dose of 29 millisieverts, while the prospective gating is only 3.5, so it's like 10 times, and this is even before the era of the iterative reconstruction. So it can really compete with radiation. What about the accuracy? Well, these are the numbers when cardiac CT was compared to the gold standard invasive coronary angiography, high sensitivity and high specificity. But what is more important is this column, the negative predictive value. The negative predictive value in all studies is very high, between 95 and 100%, meaning that if your cardiac CT is normal or negative, you can really sleep quietly. And for risk stratification, I believe that this is the future. We should prevent the future events based on data, which when the radiation dose will really go down, it will be non-issue. Let's remember the process of atherosclerosis and acute myocardial infarction. The plaque which grows and may cause acute myocardial infarction. The vulnerable plaque, it has a lipid core and a thin fibrous cap which may rupture. This plaque, as you can see here, grows basically outside the lumen and does not cause significant stenosis. Thus, more than half of acute MIs occur in plaques that result in less than 50% stenosis before the rupture. How does this work with CT? This is a patient who had CT. This is his left anterior descending coronary artery. It looks patent and normal. However, if we look carefully, we can see this plaque, which has positive remodeling and low attenuation, and we believe that this might represent the vulnerable plaque. This is also based upon intravascular ultrasound correlation with CT. And if we look back, this patient also had invasive angiography for other reasons. You can see that no one can, even in retrospective, identify this positive remodeling plaque which might change the future of this patient. And very nicely, Motoyama has shown on over 1,000 patients when they analyze the plaques on CT coronary angiography and follow up for acute coronary syndrome for more than 2 years. Those patients, there were 45 patients who had this kind of plaque, the low attenuation positive remodeling plaque. 10 out of 45 patients, 22%, had acute coronary syndrome during the 2 years follow-up, while of the other 820 plaques with neither this feature, there were only 4 events, and none of the 167 patients with normal coronary arteries had acute coronary syndrome. So we can really conclude that patients with this kind of plaques are at higher risk for acute coronary syndrome, and prevention is what they need. This is a picture from that article. You can see the positive remodeling low attenuation plaque on the coronary CT, which was acquired 6 months before the acute coronary syndrome here with almost obstruction of the LAD during the acute MI. And another recently published article in Radiology, which looked at the total extent of the plaques, found that the total extent of the plaque is the strongest predictor of major adverse cardiac events, and it is independent of the traditional risk factors or the coronary artery calcium score. And now what's beyond the coronaries? One of the advantages of CT is the large field of view. We can inject more contrast, open the field of view in order to see also the lungs, and have a triple rule-out protocol, which includes ruling out not only coronary artery, but artery disease, but also aortic dissection and pulmonary embolism. This is all done in one scan, giving more contrast in order to opacify also the right cardiac system and the pulmonary arteries. And sometimes really the symptomatology is not so clear, and the clinicians hesitate between pulmonary embolism and acute coronary syndrome. This patient had multiple risk factors, and it was just after a long flight, and we did this triple rule-out study. You can see that his coronaries are perfectly normal. However, he did have these multiple filling defects consistent with pulmonary embolism, bilateral and centrally located. Another patient who had chest pain radiating to the back with differential diagnosis of coronary syndrome and aortic syndrome. And here you can see in this reformation how nicely we can see this tiny defect in the aortic intima in the ascending aorta causing intramural hematoma, while the coronary arteries were perfectly normal, and this data together was enough for going for surgery for intramural hematoma of the ascending aorta. And now for acute chest pain. We know that coronary artery disease manifesting as chest pain is a major public health problem and the #1 killer in the world. Acute coronary syndrome, as we remember, includes unstable angina pectoris and MI with or without ST segment elevation. Diagnosis of MI is based upon symptoms, ECG changes, and markers of myocardial necrosis in the blood, while unstable angina is only cardiac ischemia without biochemical evidence of cardiac myocyte death. You should also know that only less than 5% of patients presenting to the ER with acute chest pain actually have ST elevation MI, and these are immediately sent, of course, for catheterizations. And only 70% of the patients presenting to the ER with acute chest pain will be diagnosed with acute coronary syndrome. Thus, most patients with suspected acute coronary syndrome are hospitalized for further evaluation, and eventually they do not suffer from acute coronary syndrome, and many of them are in fact free of coronary artery disease. Unfortunately, even after detailed assessment, which include ECG, cardiac enzymes, and risk stratification, a considerable proportion, like 5% of patients with acute MI, are inappropriately discharged. And mortality among those patients that were discharged is very high, and this results expensive workup and many malpractice claims. And thus, a variety of non-invasive cardiac imaging tests are in use, but those are very time-consuming and associated with high costs. So optimal triage in the emergency room will be good if we could have a quick, non-invasive, cost-effective test to identify all patients with acute coronary syndrome, and accurately identify patients in whom significant coronary artery disease can be excluded and who can thus safely be immediately discharged. And I'm going to suggest that MDCT can do that work. So the first publication was in 2007 by Goldstein, who did a randomized controlled study on 200 patients presenting with low-risk acute chest pain to the ER, and they were randomized to one arm of MDCT and the other standard of care, meaning myocardial perfusion imaging stress test in nuclear medicine. Those who had CT with minimal disease or no disease were discharged immediately. Those with more than 70% stenosis were sent for catheterization, and those with intermediate results were sent for stress MPI. Both arms showed no major cardiac events at 6 months. However, in the CT arm, 75% of the patients had an immediate diagnosis. 67 were excluded of coronary artery disease, and 8% had significant coronary artery disease. And that they found that MDCT reduced the diagnostic time to 3.4 hours versus 15 hours, lowered the costs, and also there were fewer repeat admissions to the ER due to recurrent chest pain in those patients who had MDCT. And the randomized study, which was much larger in 16 US centers, which did almost the same, showed the same results, and they state coronary CTA is faster, cheaper, and safe. So the associations of cardiac imaging, cardiac radiology, all stated in their appropriate use criteria for cardiac computed tomography that in case of acute symptoms, the suspicion of acute coronary syndrome, and normal ECG and cardiac biomarker, or ECG which is uninterpretable, it is, and low pretest probability for coronary artery disease or intermediate pretest probability of coronary artery disease, it is appropriate to perform coronary CT angiography. And the Israeli Radiological Association with the Cardiological Association also endorsed these recommendations and published 19 indications for appropriate use of cardiac CT, which you can find here in Al-Fu'a. And among those indications, one of the most used one is when there is acute chest pain with low to intermediate probability and no enzyme or ECG signs, you can do cardiac CT. So here are some examples of our own. This is a 35-year-old patient with recent onset of chest pain during exercise. You can see this non-calcified plaque causing significant stenosis in the LAD. Here it is in large plaque, significant stenosis. This is the culprit lesion. This is how his invasive catheterization looked like before performing the PCI, and see how similar it is to the cardiac CT angiography. And he had absolutely no calcium. Another patient, hyperlipidemia, no specific ECG changes, no troponin. You see significant stenosis at the distal RCA, and see how similar is the catheterization. Another patient, different story. Again, some risk factors, but here, 56 female, acute chest pain. We did a CT angiography, absolutely no plaques. She is normal, she can go home and sleep quietly. Well, another patient, even younger, with some risk factors, presenting with same presentation, you see that her LAD is quite patent. However, we can see that she has this low attenuation, positive remodeling plaque, and this is very significant for her future to get secondary prevention therapy. Another patient, same data, you can see here at the LAD origin, positive remodeling plaque causing non-significant stenosis, and another one which caused significant stenosis at the middle LAD. Here are the pictures from the catheterization, middle LAD and proximal LAD. But it's not only that, we don't have only the coronary arteries. When we look at the pictures just below, you can see that there is some shunt from left to the right, from the left atrium to the right atrium. And what's going on here on this sagittal formation? This is the shunt, and the coronary sinus was draining not into the right atrium, but to the left atrium. Very interesting. So this is a rare type of SD, which is called unroofed coronary sinus. And you can see that the right heart is already dilated, meaning that there is hemodynamic significance for this finding. And all this data, including the coronary assessment, was in that same scan. And now shortly for advanced applications. The coronary flow reserve is reduced in rest only when there is stenosis of more than 85%. However, during stress or exercise, the reserve will be reduced when there is over 50% stenosis. And the decision to treat the stenosis should depend on the functional significance of the lesion, requiring the use of some kind of stress, either exercise or pharmacologic. And as you know, CT angiography is just an anatomical study. So now we believe that in the era of the post-64 slices, when we have scanners like this 320 slice, which can cover the whole heart in one cardiac beat, or the dual source scanners with wonderful temporal resolution of less than 75 milliseconds, it might be, we might be able to appreciate the perfusion of the myocardium as well as the coronary arteries. And I just took one of the studies that are running now, the CORE 320 study, which is done on a 320 multi-detector CT. And it's designed to investigate the diagnostic performance of 320 detector rows for detecting coronary artery disease and associated myocardial ischemia. So what they are going to do is compare the combination of coronary CT angiography with CT perfusion at rest and stress, all non-invasive assessment in one study, versus invasive coronary angiography plus SPECT perfusion in rest and stress. And the timeline they suggest to do it is following the calcium score to inject and do the rest coronary CT angiography, and then if it's almost normal, the patient is discharged. However, if there are some borderline plaques, then adenosine infusion is started, followed by stress CT perfusion, and then it could also have delayed enhancement CT, which is, I don't have the time to talk about, but in this way we can have also stress and rest CTA for evaluation of myocardial ischemia. And this is an example of a normal stress polar map, while there is a reduction in the perfusion in the inferior lateral and apical segments. And here are his coronary angiography CT. You see moderate stenosis at the LAD and significant stenosis at a marginal branch. So this is interesting. And another advanced application which is I think something like science fiction, is this one, fractional flow reserve. As you know, fractional flow reserve is the index of the physiological significance of coronary stenosis. It's the ratio of maximal blood flow in stenotic artery relative to the normal maximal flow. And the measurements are done during invasive coronary angiography using a pressure guide wire. Measurement of FFR during invasive coronary angiography is considered the gold standard for identifying coronary artery lesion that causes ischemia. So if there is some borderline lesion or even a 70% lesion, if there is FFR of less than 0.8, it means that this lesion causes ischemia, while if it's above it, it's not useful to do PCI to this lesion. PCI guided by FFR measurements improve the outcome by multiple studies like this one and some more. Could we do it by CT? So there's a group which did computational fluid dynamics using some supercomputers. Each study took more than 5 hours for analysis, but they did quantify the FFR out of the CTA images. and they did compare the FFR CT with the invasive coronary angiography FFR, and they found that, of course, the FFR CT improved the accuracy of the coronary CT angiography alone, and also there was a good correlation between the FFR CT and the FFR which was measured during invasive coronary angiography, and I think this is very exciting. And here are some images, the moderate stenosis at the LAD on CT, and the calculations of the FFR. Here it's above 0.8, it's 0.85, so it's not significant. And same FFR, the lesion actually looked more severe during invasive angiography. However, you can see that the FFR was the same, so do not treat this lesion. And another lesion here in the proximal LAD with a very significant reduction of the FFR in the distal LAD and less significant in the diagonal branch. And these are the CT measurements, and the gold standard invasive coronary angiography measurements were actually very, very similar. So we can conclude that cardiac CTA is safe, accurate, and efficient for acute chest pain assessment, and significant progress in both scanner technology and post-processing opens horizons for extended applications that will allow a comprehensive, non-invasive cardiac evaluation. Thank you. I'd like to thank all you who did the job.